Good afternoon, everyone, and welcome to Providence Grand Rounds. We have an outstanding topic today by an international expert. Dr. Philip Mease will be speaking on early identification and diagnosis of axial spondyloarthritis. Next slide. Regarding our logistics, all of the attendees are muted. And please use the question and answer box to ask questions. We do look at the chat as well, but we prefer you use the question and answer box. And this presentation will be recorded, including in video, and it'll be posted on the Caregiver Grand Rounds site, where previous Grand Rounds are also available. Next slide. This is our continuing education information, and this will also be posted in the chat, and you can see the instructions for obtaining your continuing education. Next slide. These are our disclosures, and none of the planners have any relevant disclosures. Dr. Mease is a researcher, consultant, and speaker, and does have some disclosures, and they are provided in more detail on the next slide. So we can go to that slide. And I'll give you a second to look at those. Then we're very pleased today that Michael Griffin, leader of our Orthopedics and Sports Medicine Institute, will be providing a reflection to kick us off.
Thank you, Dr. Bernstein, and good afternoon, everyone. I'd share this reflection from the 13th century poet Rumi because it is something that I came across as a very young man and feeling quite rebellious at the time and not wanting to take advice from all these people who wanted to give me that advice, who had never left home. As I was preparing to leave home, it really stuck with me. And when setting out on a journey, do not seek advice from those who have never left home. But as I have grown and matured and hopefully learned along the way, I realized that there's another way of looking at this. And it's that if we move forward from the 13th century Persia to the late 1889 in Johns Hopkins, a place we're all familiar with and great healthcare renown, Dr. William Ulcer started Grand Rounds at Johns Hopkins. Originally, they were called amphitheater rounds, and I am so dated in this practice of medicine that I actually have been in one of those amphitheaters before. But the Dr. Ulcer wrote so touchingly, I thought, that the objective of their Grand Rounds is to demonstrate the best in the analysis and treatment of difficult clinical problems in real life patients who often tell their own story. The patient remains our link between current research and modern therapeutics. And as I have come to know and appreciate the rheumatologists that we have a few key thought leaders in rheumatology in Providence. I can't think of any people that I work with more who embody what Dr. Olson said. And actually, Rumi doesn't know the expert path that we're going to talk about more today, and that Dr. Mease is going to share with you. So I'll turn it back over to you, Dr. Bernstein.
Well, thank you, Michael, for that very informative and pertinent reflection. You gave us all something to think about as we listen to the Grand Rounds. Appreciate that. Next slide, please. So these are the learning objectives for today's session, that the participants will have an increased ability to develop an awareness of axial spondyloarthritis as a treatable cause of back pain, recognize an inflammatory back pain pattern as the typical presentation of this disorder, identify other common clinical features of axial spondyloarthritis that occur outside the spine, develop appropriate testing for a patient with chronic back pain where this disorder may be suspected, and apply criteria for referral to rheumatology, and review knowledge of basic principles of diagnosis and treatment of axial spondyloarthritis as applied by rheumatologists. Now it's my great pleasure to introduce our speaker today, Dr. Philip Mease. Dr. Mease is Director of Rheumatology Research at Swedish Medical Center and a clinical professor at the University of Washington School of Medicine in Seattle. The clinic is part of Providence Connect as well. Dr. Mease earned his undergraduate and medical degrees at Stanford University. He then completed his residency in internal medicine and a fellowship in rheumatology at the University of Washington. Dr. Mease's research interests include psoriatic arthritis and spondyloarthritis, rheumatoid arthritis, osteoarthritis, fibromyalgia, and osteoporosis. His research focuses on disease state, outcome measurement, development, and determining the efficacy and safety of emerging therapies for these conditions. His seminal 2000 Lancet paper established the efficacy of anti-tumor necrosis factor therapy in psoriatic arthritis. He's authored over 500 journal articles and many hundreds of abstracts, book chapters, and edited textbooks on psoriatic arthritis and axial spondyloarthritis. Dr. Mease is a prolific international speaker at academic congresses, grand rounds, and other educational activities for rheumatologists and dermatologists, and is considered an international key opinion leader, researcher, educator, and clinician regarding spondyloarthritis, including psoriatic arthritis, ankylosing spondylitis, and non-radiographic spondyloarthropathies. He's a reviewer for many journals, including the New England Journal of Medicine, Lancet, Arthritis and Rheumatology, and others. And Expertscape ranks Dr. Mease as the most published expert in psoriatic arthritis worldwide and the 24th most published expert the past decade in axial spondyloarthropathies. So it's really our great pleasure to have such a noted expert to speak to us on this fascinating topic. Dr. Mease, thank you.
Thanks very much, Michael, and also Michael Griffin, for that was a very inspiring dissertation about both Rumi and Dr. Osler. Let me know if this is not visible, but can you see this, I presume?
It's all good.
Okay, good. So here we go. Let's have some fun as well as learning. What our goal is for you to have a greater appreciation for the potential for finding an inflammatory spondyloarthritis condition in your patients presenting with back pain. So we're going to start with a case. This is a 34-year-old male who has had back pain over the last 6 months that's not relieved by rest and often causes him to wake up in the middle of the night, typically around 2 in the morning, and he finds himself having to get up from bed in order to walk around in order to relieve the pain. Pretty irritating to his wife. He's also got quite a bit of morning pain and stiffness. He does find that over-the-counter nonsteroidals are partially helpful, but the condition has been worsening, and it's really impacting his quality of life. X-rays obtained by his PCP show some modest degenerative changes. He's referred to physical therapy, and he's also referred to a physiatrist at a pain clinic. At the physiatry evaluation, he's found to have a bit of tenderness over the left SI joint area. He doesn't have any evidence of peripheral joint involvement, such as swelling of synovitis, enthesitis, which means inflammation where a tendon or ligament inserts into bone, such as the heel, or dactylitis. And dactylitis is the phenomenon of swelling of a whole digit. So it looks like a sausage, which reflects inflammation not only in the joints of the digit, but also the tendons and bone. He's got pelvis X-ray, which looks normal. There's no change in the sacroiliac joints or the symphysis pubis or the hips. His CRP, interestingly, is slightly elevated, and the physiatrist was aware enough to obtain a gene marker known as HLA-B27, which ended up being positive. He was given prescription meloxicam to see if that made any difference compared to over-the-counter nonsteroidals, and was referred on to rheumatology. So in the rheumatology evaluation, we applied the inflammatory back pain criteria. And shortly, I'm going to show you a slide which lists the questions that we ask in relation to this and how this helps us distinguish inflammatory back pain from mechanical back pain or, say, fibromyalgia. He has no family history of a spondyloarthritis or related conditions, no history of uveitis, IBD, or psoriasis. So what further lab or imaging might we order at this time? And I've given you the clue here, pelvis and lumbar MRI. And then what therapeutic intervention might we suggest? And I'll save that discussion until we get to the therapeutics part of this talk. So here are examples of MRI scans of the pelvis, sacroiliac joints that show light up. So we have, for example, in C, which is the most dramatic here, a T2 stir image, which shows whitening of the bone adjacent to the sacroiliac joints. This represents lymphocytic infiltrate into the bone, i.e. inflammation. This is also seen, for example, in A and D. B happens to be a T1 image, which shows darkening where sites of inflammation are. So this is a key finding. Normal X-ray of the sacroiliac joints, so no damage has occurred in terms of erosion of the joint or narrowing of the joint or ankylosis of the joint, but there is inflammatory infiltrate which causes pain and stiffness. Here we have an image of the lumbar spine, lateral view by MRI, and the arrows are pointing toward places of light up in the vertebral bodies where inflammation is occurring. Again, lymphocytic infiltrate. And not shown as well here, but there can be inflammation in posterior articular facet elements as well. So that was a very quick introduction to a not unusual case and how the patient had, it wasn't that long a journey actually, PCP to physiatrist and then to rheumatologist. We see lots of people who bounce around from clinician to clinician, and it may be quite a long journey. So here is a classic picture of a patient with what we have historically called ankylosing spondylitis, and I'm going to be teaching you about the new nomenclature that we're using. It's a chronic inflammatory disease, as noted. The axial skeleton is principally involved, but also peripheral joints, typically just a few, often asymmetrically involved, and extra-articular organs such as the eye, the gut, or the skin. The patient will have really severe back pain typically, which it impairs their ability to function and quality of life. They have impaired spinal mobility and diminished chest expansion, which represents a risk for them if they develop pneumonia and can't have adequate pulmonary toilet. Enthesitis, again, anywhere where a tendon or ligament inserts into bone, such as the heel, and then associated conditions. And a key feature is sacroiliac joint involvement. How many times have I had patients come in who've had multiple different views of their lumbar spine, including MRI, but no look at the SI joints? So you need to have a pelvis X-ray and a pelvis MRI with a focus on the bony abnormalities in order to really look at this particular set of joints. I'm going to show you in a moment the inflammatory back pain criteria. Oftentimes the patients have a good initial response to nonsteroidals, but most patients don't find that adequate ultimately and need to move on to more advanced therapies. It's a very heritable disease, and there's often a positive family history for spondyloarthritis. On physical exam, you can find back pain, such as this patient we just were with, where There was some tenderness with percussion over the left SI joint, but oftentimes the back exam is not terribly revealing. Shown here is inflammation where the Achilles tendon is inserting. Typically, you don't see anything, but more often it's just simply the patient reports pain in that area or in the plantar fascia or around the patella of the knee, for example. Oftentimes the joint involvement may be asymmetric, as shown here with the right knee of this patient being inflamed, but the left knee not. And then the eye, gut, and skin are depicted here with uveitis, inflammatory bowel disease, and psoriasis. Laboratory is really pretty sparse. We may well check the genetic marker HLA-B27, which is present in about 80% of patients, but leaves about 20% of patients without abnormal HLA-B20 or presence of HLA-B27. And then a CRP and SED rate, which look for evidence of inflammation. There is no biomarker like an ANA or rheumatoid factor that we can use to make a diagnosis. Imaging, we're going to get into a lot more. So here is the inflammatory back pain criteria, and I direct your attention to the box on the right here. This is the most recent version of these criteria. So what are they? Age at onset of less than 40 years of age, insidious onset of the back pain, improvement with exercise, no improvement with rest, and pain awakening the patient at night with improvement upon getting up from bed. In historical versions of this, there's also morning stiffness that may be present, but that has dropped away because it is not as specific. So these are things to sort of commit to memory, and especially the point of the patient saying that my pain actually gets better when I'm getting up and moving about, and no improvement with rest. And this nocturnal pain is really a key finding as well. Now, in later stages of classic ankylosing spondylitis, this is what it looks like, where there's ossification of the spine, these syndesmophytes that are bridging across the vertebral bodies, and the patient typically has a stooped posture. On the right, we see this classic set of photographs of a fellow who was in the Canadian Royal Mounted Police, and it shows his gradual progression of ankylosing spondylitis. In 1973, he's a bit more upright, and that's because he's had hip replacements. Unfortunately, the year after these photographs were taken, he passed away as a result of aortic valve disease, which can be a part of the spectrum of the disease. Here we have an older sort of image which shows the relationship between a number of different conditions which are genetically related to each other. Ankylosing spondylitis, psoriatic arthritis, psoriasis, so-called reactive arthritis, which is triggered by infections like Salmonella or Shigella, arthritis associated with inflammatory bowel disease, and what we call undifferentiated spondyloarthritis, as well as IBD here. So these are clustered from a genetic point of view, and it's not unusual to see evidence of one or the other in the patient in front of you. Here is an older criteria for what was called at the time ankylosing spondylitis, published in 1984. And there's some clinical criteria, including chronic back pain, some limitation of motion. But a requisite element was finding of sacroiliitis grade 2 bilaterally or grade 3 or 4 unilaterally. And so we're going to look at that in the next slide. But the point being that evidence of radiologically defined damage was required for a person to have a classification of ankylosing spondylitis. As you will come to see, that means that the patient already has quite advanced disease, and it is often beyond the point where we can ideally take care of it. Here are images of the SI joints. They take us through 1, 2, 3, and 4 grade of sacroiliitis on X-ray. So grade 1 means just a little bit of periarticular sclerosis. Oftentimes it's very difficult to discern this, and it is not a part of the ankylosing spondylitis criteria. You have to have at least grade 2, which is the next one on the right, showing more periarticular sclerosis and some irregularity of the joint. Grade 3 on the lower left is even more so. And then grade 4 is complete ankylosis of the SI joints. How often have I had people come in with ankylosis of the SI joints, and the radiologist's interpretation is no hip fracture present? So here we have an example. We have a set of SI joints that are visible in this radiograph, and it's a little unclear whether there's any abnormality or not. And it's a little bit hard to tell because of overlying bowel gas. So this interpreter says, well, maybe it's grade 0 on the left, this patient's left, and maybe grade 1 or 2 on this patient's right. So here we are introducing the term non-radiographic axial SPA, which I'll speak to you about in a little bit more in a moment. But this is where they don't have clear-cut sacroiliac changes grade 2, 3, or 4. So now we need to put in clinical context. Here we have, for example, a female who's almost 60, long-standing low back pain. Maybe she answers the inflammatory back pain criteria positively. She happens to be B27 gene marker negative, minimal response to nonsteroidals, and no other spondyloarthritis features. Versus a male, 32 years old, low back pain for 3 years, clearly endorsing inflammatory back pain criteria. He's positive for the gene marker HLA-B27, good response to nonsteroidals, no other spondyloarthritis features. Let's look at the MRI scans that go along with these. And it's very clear that the younger male lights up considerably with evidence of inflammation from lymphocytic infiltration in the bone adjacent to the sacroiliac joint. And then down below, the older female, not any abnormality. And so we're looking for a different reason, such as mechanical back pain or fibromyalgia for her pain. So recognizing the limitations that were imbued by requiring evidence of sacroiliac damage on X-ray, if we fast forward to 2009, we now have the current axial spondyloarthritis criteria. And notice the name change. What we're doing is we're trying to get at diagnosing it earlier in a patient's experience of it, before there's ankylosis, for example. And we're emphasizing the spinal element, and also the newer term spondyloarthritis rather than spondylitis. So what are the criteria? In patients with at least 3 months of back pain and age at onset of their back pain at less than 45 years of age. And then they can come into the criteria by 2 pathways. On the left, an imaging pathway, which can be either the characteristic radiographic changes we looked at just now, or evidence of inflammation in MRI scans. And then at least one of the spondyloarthritis clinical features that's in the gray box in the middle. Inflammatory back pain, typically lower extremity arthritis, asymmetric, enthesitis of the heel, uveitis, dactylitis, psoriasis, Crohn's or ulcerative colitis, good response to nonsteroidals, family history, positive B27 or elevated CRP. So there are lots of different ways in which a patient can qualify if they have the appropriate imaging. On the right hand, the so-called clinical criteria. So if the patient has a positive HLA-B27 gene marker and at least 2 of the spondyloarthritis features in the gray box in the middle, then that will qualify them as well. So what we have discovered, now that we are using MRI extensively, we're checking B27 more frequently, what we're discovering is several different things. We're finding a lot more people that do qualify for having axial spondyloarthritis. And then also we're finding more females, whereas it used to be considered predominantly a male disease. We're now finding that it's actually equigender when we include all these patients. And this opens up what we now call radiographic axial spondyloarthritis, where they have changes on the X-rays of the SI joints, as well as, quote, non-radiographic, where the sacroiliac X-ray is normal, but the MRI may be abnormal. So this is depicted here. If we look on the left-hand side, we see a patient who is still in the non-radiographic stage with MRI changes around the sacroiliac joints, but also in the lower left-hand part, a patient who doesn't light up in the MRI of the SI joints, but they're HLA-B27 positive and have other spondyloarthritis features. Then as we move over to the right, we see the classic radiographic changes in the SI joints and the spine. Turns out that about half of the patients with axial spondyloarthritis are on the left-hand side of this slide, and about half are on the right-hand side of the slide. So if we learn that based on an in-hand study that up to about 20% of the US population has chronic low back pain, about 5% will endorse inflammatory back pain criteria, 1.4% will have evidence of axial spondyloarthritis, including this non-radiographic form, and 0.5% will have ankylosing spondylitis. And we learn from these 2 German cohorts that this point about the fact that whereas the historical ankylosing spondylitis is predominantly male, as shown here on the female row, only about a third are female that have AS. The non-radiographic group actually ranges from 57 to 68% of the non-radiographic population. So I think of this as kind of a gender justice issue that we have historically really missed, making the diagnosis in many women, calling them either fibromyalgia or mechanical back pain, and not getting them access to effective treatment. We also see that HLA-B27 positive status is present in over 70% of these patients. Just to mention very quickly that there's also a peripheral spondyloarthritis criteria, wherein a patient who maybe doesn't have much or any back pain, but who has peripheral arthritis, enthesitis, where tendons or ligaments insert into bone, say around the rib cage or the patella or the heel, or dactylitis, this sausage digit change, plus one of these characteristic spondyloarthritis features noted below, they can be classified as having what we call peripheral spondyloarthritis. So this gives us this kind of Venn diagram that shows how we're now characterizing these patients as being primarily axial in presentation, either non-radiographic or radiographic, or more peripheral in presentation. And many of the other forms of spondyloarthritis that I showed you earlier, like psoriatic arthritis, the arthritis associated with inflammatory bowel disease, reactive arthritis, are more in that particular camp. And this gives us, if we think of a Northwest river, the authors here are from Portland, and they came up with this cartoon. And it shows the evolution of the patient over time, starting in a non-radiographic, first of all, just with inflammatory back pain features, then evolving into non-radiographic axial SPA, There might be periods of time when their disease goes into quiescence. And then down the road, they ultimately develop either the classic radiographic form of ankylosing spondylitis that can be quite severe, or remain in the non-radiographic state. Now, there are a number of other features that I've already mentioned previously, such as uveitis, psoriasis, IBD, and then some less frequent problems such as pulmonary fibrosis, aortic valve abnormalities, arachnoiditis, and so on that may occur in these patients. Here's an example of a patient with uveitis, and the comment is made that 15 to 25% will have evidence of episodes of uveitis at the time of initial presentation, and up to 50% may ultimately develop signs of uveitis. So we work in conjunction with ophthalmologists in caring for this particular aspect of disease. Inflammatory bowel disease is present in somewhere between 5 and 8% of AxSpA patients. But what is important to know is that when you do colonoscopies, you can find up to 60% of the patients having subtle abnormalities of histologic change, including some dusting of lymphocytes that are present in these biopsies, suggesting subclinical disease. And sometimes this may flare up and become a more overt clinical problem that needs addressing. And so again, just like in the previous slide with ophthalmology, it's very valuable to have a good teamwork between rheumatologist and gastroenterologist in the care of these patients, and in thinking about the choice of medications that would cover both conditions. And then finally, psoriasis, which occurs commonly in the population, about 3% of patients, and about 10% of AxSpA patients will have evidence of psoriasis. And again, teamwork with dermatologists for care of this problem. There are a few other comorbidities to mention, and I think one of the key ones is depression. It's so classic that in our hurry through the day, we sometimes don't really want to probe or get into what the mental health status of the patient is. I think primary care docs do a pretty good job of this, but I must admit in our discipline, we may not do it as well. It's a very big deal. And in my practice career, which began in the early 1980s, the only two patients in my practice that have committed suicide were two young males who had severe ankylosing spondylitis. And this was at a time when we really didn't have any meaningful therapies for the disease. So just imagine prime of their life in their 30s, trying to develop a family, be productive in work, chronic severe pain. And if you look at some of the use of opioids in this population, it tends to be very high. And we try our darndest to make sure that we're not using opioid medications in these patients. So this is a big deal. And then others that are listed here, including some rare kidney abnormalities, osteoporosis, ironically, even though these syndesmophytes are forming, and there appears to be quite a solid vertebral column, it's actually weak bone, and fracture is a common issue. Fatty liver disease, cardiac abnormalities, and so on. Here is an example of fracture in a axial spondyloarthritis patient. Now, one other comorbidity that I want to bring up, and we'll just take a second on here, is that of what we call fibromyalgia, or another term for it is central sensitization, and a newer term is called nociplastic pain. This is a condition which occurs on its own in anywhere from around 4% of the population, but it occurs quite commonly in patients with chronic painful conditions or chronic autoimmune and inflammatory diseases. Here I've just listed a few of the rheumatic conditions and some of the studies which show us that on average, somewhere around 15 to 20% of patients with these conditions will have concomitant fibromyalgia. Here's an example of a study done in Brazil where a percent, I think this is around 13% of the patients in this particular study had both ankylosing spondylitis and fibromyalgia. And as you can see, these various measures that we use to measure the disease activity or quality of life were twice as severely impacted in the patients with fibromyalgia as those without. And so this is an important consideration when we're thinking about, when we're assessing how our patient is doing. We need to take into account, is there background fibromyalgia that's negatively influencing our evaluation of the patient. And just a reminder about how fibromyalgia works. This just shows you some basics about the neurobiology of pain transmission in the central nervous system with an ascending pain pathway mediated by a number of different neuropeptides and what we call an inhibitory descending pathway mediated by neuropeptides like norepinephrine and serotonin, opioids, cannabinoids, and so forth. And in most of us, it's a fine balance between these two. But in fibro patients, there's too much of the ascending nociceptive process and too little of the inhibitory process. And this is exemplified here in a study done by Rick Gracely a number of years ago, in which he demonstrated using fMRI and then using a pressure stimulus to the patient's finger, showing that even with a small amount of pressure intensity, the patient with fibromyalgia was experiencing much more severe pain than the normal individual. And this was verified by showing light up in the areas of the brain for pain processing. We know that this is influenced by a number of factors, including the genetic profile of the patient, and there are certain genes that make it more likely that the patient will develop fibromyalgia. And then the influence of their whatever disease activity that they have going on, in this case, rheumatic disease, as well as background features such as mood disorders, depression, anxiety, leading to this state of chronic pain amplification. So keep this in mind. Now I want to just spend the last bit on just a quick overview of the treatment approaches that we are able to use in rheumatology to really effectively treat this condition, which we used to not be able to do before the year 2000 or so. So our goals of therapy include reduction of pain, improving physical function, improving quality of life, including fatigue, which is a common concomitant of AxSpA, participation in meaningful life activities, and work capability. We want to be able to improve conditions like uveitis, IBD, and psoriasis, treat comorbidities and reduce their impact, and prolong life expectancy. So these are the kinds of points that I'm making with a patient when I'm getting to know them and getting to make the diagnosis for the first time. It's very important to have this kind of conversation to share your expectations of what you can achieve. So here's a diagram from the US-based treatment guidelines for axial spondyloarthritis developed by the American College of Rheumatology, the Spartan Association, and the Spondyloarthritis Association of America. And the first step pharmacologically is to try at least 2 different nonsteroidals for at least 2 weeks. And if the patient tolerates that okay and gets benefit, then that is good. Those can be continued with appropriate monitoring, for example, creatinine and so forth. Physical therapy is also key, and we try to avoid systemic steroids, and we try to avoid opioids, as I mentioned earlier. If there are peripheral manifestations, for example, peripheral joint involvement or enthesitis, then there are medicines such as methotrexate or sulfasalazine that might be considered, or doing local glucocorticoid injections, although we avoid injecting the Achilles tendon insertion, for example. Most of the time, when a patient has gotten to a rheumatologist, they've already been through nonsteroidals, they have had inadequate response, or they can't tolerate them. And so we're at what we call the point of second-line therapy. And this is where the medicines that we call biologics come into play. And since 2000, we've really had a explosion of understanding and studies that really help us understand the role of these targeted immunologic treatments for not only axial SPA and psoriatic arthritis, but also rheumatoid arthritis, lupus, and so forth. So as a rheumatologist who started practice in the early 80s, when we were just beyond using weekly gold injections for treating rheumatoid arthritis and psoriatic arthritis, just beginning to use methotrexate, now we have a wonderful group of medicines that really are able to put the patient into a state of low disease activity or remission oftentimes. So the first set of drugs that we typically will reach for are the TNF inhibitor class, and I'll show you in a moment those, but there are 5 of them that we have access to, several that are given as subcutaneous injections by the patient themselves periodically, and some that are infused. If the patient happens to have uveitis or IBD or psoriasis, then we tend to use the monoclonal antibody form of TNF inhibitors. And then if we're running into issues where we're not sure that we're getting a response, it's always worthwhile to maybe reevaluate the pelvis MRI, see if there's a diminution of the inflammation changes, and or considering whether there are other diagnoses at hand, including fibromyalgia. And then always making sure that we're keeping the patient educated, we're asking about potential toxicities of these medications, such as infection, and encouraging physical exercise and conditioning, for example, and encouraging weight loss. Here's a list of the medicines that we have used, and most of these have approval by the FDA and other agencies around the world for treatment of axial spondyloarthritis. The first 5 of these are anti-TNF medications, as they're called, including ones we've known about for a long time, such as etanercept or adalimumab, as well as infliximab, golimumab, and certolizumab. Also listed are interleukin-17 inhibitors, bimekizumab, which is in the process of being studied for approval, brodalumab, which is not approved for ankylosing spondylitis, but ixekizumab and secukinumab are approved for ankylosing spondylitis treatment. And then several oral medications known as Janus kinase inhibitors, including tofacitinib, which is approved for treatment of ankylosing spondylitis, and upadacitinib, which is soon we anticipate to be approved. So this is just showing you the fact that in clinical trials, these drugs work. They clearly reduce pain, improve function, improve quality of life, without question, compared to placebo. And then this is just showing these kinds of responses in patients with so-called non-radiographic axial SPA. That is, those that either have light up in their MRI scan, but don't have radiographic changes, or have an abnormal HLA, or a presence of an HLA-B27, and often an elevated CRP. And we have several of these medications that have been shown efficacy in this aspect of the disease as well. If the patient loses effect over time, which happens a lot, we start a medicine, let's say adalimumab or etanercept, the patient has an initial great run with it. Their pain levels go down from 8 to 2 or 1, and they tolerate the medicines well, and they come back in and they just say, "You've given me a new lease on life." It's what makes working as a rheumatologist really rewarding. But with time, there's often a loss of efficacy. Some of this may be due to development of what we call anti-drug antibodies, where the body is sensing that a foreign protein is there and develops antibodies that may neutralize the effect of the drug. There's also other factors which may lead to, if you will, immunologic. The immune system sort of gets wise and figures out a way of getting around these therapies. So we might have a run for anywhere from a year of good benefit up to 5, 6. I've had some patients with 10 years of benefit with these medications, but ultimately they do tend to lose benefit. So we're finding ourselves needing to cycle so that we are either going to a different TNF inhibitor if they've had an initial great response to a TNF inhibitor, or if they don't have a great response or a short response to a TNF inhibitor, then other modes of action, including the interleukin-17 inhibitors or the JAK inhibitors. And there are others that are coming along that are in development. One of the key questions, too, is like in rheumatoid arthritis, where use of these biologic medicines and oral effective medications have been shown to inhibit the structural damage progression of rheumatoid arthritis as measured by X-ray in peripheral joints. It's been harder to document this in axial spondyloarthritis, partly because the changes that we see in the spine tend to be fairly glacial. So in the course of a placebo-controlled trial, it's sometimes difficult to have a person on placebo long enough to see a difference between the treatment arm and the placebo arm. So here we have data from a 5-university registry known as the SOAS cohort, where they looked at a large group of patients being treated with TNF inhibitors. And it was found that if the TNF inhibitor was started early in the course of the disease, then there was evidence for inhibition of progression of the kind of changes that I showed you earlier in the spine of these patients. So there is evidence from registries of ability to inhibit structural damage progression. Here I'm just showing a single slide commenting on treatment for central sensitization or fibromyalgia, with a lot of focus on non-pharmacologic treatments, including physical therapy, conditioning exercise, cognitive behavioral therapy, and so on, but also pharmacologic. And what we focus on is non-opioid pharmacologics, including serotonin, norepinephrine reuptake inhibitors, such as duloxetine, or the gabapentin, pregabalin type treatments. One of the key issues that we have with these patients is the problem of delay of diagnosis. So if you look at studies around the world, it's almost 7 years between symptom onset and actual diagnosis of axial spondyloarthritis, whereas it's quicker with diseases like psoriatic arthritis and rheumatoid arthritis, partly because of the fact that chronic back pain is common, and it's so often the case that we just attribute it to mechanical or degenerative arthritis in the spine. And sometimes it can be much longer, up to 14 years. The other thing that is being noted here is the gap between the findings from the NHANE study, where we find that roughly 1.4% of the US population should have axial SpA if we were doing a good job of diagnosis. But if you look carefully in claims databases or rheumatology practices, et cetera, it's only about 0.2%. So there are lots of people with this condition out there that are not getting diagnosed and not getting proper treatment. These are some of the consequences of delay in diagnosis, including overall worse disease activity, worse physical function, more radiographic progression, worse quality of life, negative psychological impact, higher healthcare cost, and work disability. And these are some of the factors that lead to the delay of diagnosis, including simple lack of awareness that axial SpA may be present in the patient in front of you. The fact the patient may not have a positive or a HLA-B27 gene marker. We tend to think of this historically as a more male disease, so we tend to not think about it when a female is presenting with back pain. There's lots of racial disparities, including less diagnostic workup in patients of color. We don't have consistent referral patterns established to getting patients into a rheumatologist. Lack of validated diagnostic criteria and biomarkers. We don't have a rheumatoid factor. We don't have an ANA in axial SpA. And then there are patient level factors that may lead to lack of adequate health care. So these are just some studies that back up those points, making the point that when quizzed, many PCPs were just simply not aware of the inflammatory back pain questions and how to distinguish from mechanical back pain. That many of the people that are healthcare clinicians that are taking care of back pain patients weren't aware of the non-radiographic axial SpA category that's merged in recent years. They don't think of females and so on. And here are some of the points about why females, what the difference is, including less radiographic progression, less B27 positivity, more fibromyalgia and depression, overall expression of higher disease activity, and so on. So I'm going to wrap up here with one more case, which I think is illustrative of some of the difficulty that we have in diagnosis. Here's a 32-year-old female with persistent heel pain despite nonsteroidals, use of a heel pad, and physical therapy. She has difficulty ambulating and has to take time off from work. She has evidence on exam of right Achilles tendon and plantar fascia insertion pain. A lateral foot x-ray doesn't show any abnormality of the heel or the ankle. There are no heel enthesophytes, for example, or spurs. So she gets referred to rheumatology, gratefully. So on rheumatology visitation, she actually acknowledges that she's had subtle low back pain, which she just kind of attributed to posture or what have you. She didn't even think about it in relation to her heel. So now we have a choice. What would we do next? We might get some lab, a CRP or HLA-B27. We might get some more advanced imaging of the heel, including ultrasound and or MRI, but also let's now look at imaging of the pelvis and lumbar spine. So here we have on the left a heel MRI, which shows where the arrows are pointing, light up in the bone adjacent to the Achilles tendon insertion, which is representative of osteitis, where this enthesial inflammation is occurring, and then at the plantar fascia insertion as well. And on the right, we're showing evidence of power Doppler signal in an ultrasound of the Achilles tendon insertion, which we can do just right there in the office. Now, the patient has a slightly elevated SED rate and slightly elevated CRP. That's intriguing. Her HLA-B27 is negative. Her sacroiliac joints are considered to be completely normal by the radiographic interpretation. But we've got these clues, including the slightly abnormal acute phase reactants. We have a pelvis MRI here, which shows activity, inflammatory light up in the bone adjacent to the sacroiliac joints. So that's very important information. And so in our follow-up with the patient, we have diagnosed her as having non-radiographic axial SPA with both axial and peripheral manifestations, sacroiliitis and heel enthesitis. We're going to continue non-steroidal therapy because she's tolerating and getting some benefit from it. And we're going to initiate either a TNF inhibitor or an IL-17 inhibitor. And I would anticipate good response. So to summarize, this is my last slide. Axial SPA is a relatively common immune-mediated inflammatory condition occurring in up to 1.4% of the population. Remember to ask inflammatory back pain questions. Age of onset, less than 40. Improvement of pain with activity. No improvement with rest. Getting up in the middle of the night because of pain, and insidious rather than sudden onset. And think about the sacroiliac joints and imaging them. Axial SPA may have associated conditions and comorbidities which need to be taken into account and managed. We've had terrific treatment advances over the last 2 decades so that we can now get to it just revolutionized our ability to take care of these patients. It's very important to keep educating so people know about the possibility of this condition, and ask your local friendly rheumatologist who is standing by to help guide optimal management. So with that, I'll stop